Kia ora, mai iti hui anā. Hello to all who have gathered, and thanks for the privilege of being able to talk today. I'm very confident that we're going to move to a data-based world, where data, as we've seen in the previous talks, predicts human behaviour. And understanding data is really important to delivering the correct services and at the right time to the right people. Ageing is a big challenge in New Zealand, we all know that. The ageing population is complex and introducing challenges that we've never seen before. And not only that is it costly, it's a big cost to New Zealand. And I'm certain that understanding data around ageing is going to help us deliver better care and save money for New Zealand. New Zealand's got a novel data set on ageing, which many of you will already know about. And here I want to talk about some examples about how we've used this data set, but also importantly, how we're going to translate this knowledge. Because it's not only doing the research, it's having a clear path to translation that's really important. So in this talk, after the introduction, I wanted to explain three key areas of big data and ageing that we've explored. Social isolation and drug burden index. They were both sponsored by the Ageing Well National Science Challenge, and Frailty has been sponsored by the HRC. Following that, I talk about an interventional program that we're involved with and trial, and also, again, concentrating on impact, because I think it's important not just to do the research, but as I totally agree with MB and the National Science Strategies, we need to be out there to make sure that this research is applied to benefit New Zealand. The big data source which we're using in New Zealand is the interRAI. How many people here have heard of the interRAI, just out of interest? Many people. What it is it's this international collaboration to improve the quality of life across many people, but in this case in New Zealand it's mainly been with older people. And New Zealand's chosen it for a standardised assessment for people aged over 65 with complex needs. These are the sort of people who start needing home services and that they aren't in rest homes. We're doing about 30,000 assessments per year, and it's a very comprehensive assessment. It's multidisciplinary, including things like loneliness, body mass index, and falls in the 236-item assessment. It's NHI linked, so we can efficiently have this linked with other New Zealand data sets. It's all linked at the Ministry of Health and provided to us anonymised. Everyone's consented when they get an interRAI if they're happy for their data to be used, and there's a 93% success rate. Oh, it's 93% agreement to having their data used. And fundamentally, I think data is going to drive management of ageing. This is on the wall of Canterbury CDHB Decision Support, where they're becoming very data-based as how they deal with the challenges of all society, particularly, or including the ageing population. I just wanted to move on and talk now about some specific examples around what the interRAI data is showing with ageing, and one of them is to do with loneliness. And I originally come from Greymouth or Mawhera, where we have a relatively strong community support. And the idea of loneliness for communities and for older people, I wasn't really familiar with. But understanding the impact, the prevalence of loneliness and the impact it's having on individuals, their whānau and their community is important. And national averages from the interRAI using tens of thousands of home care assessments show that there's an average of 21% of older adults reported as lonely. There was slight differences in different cultures. In Maori cultures are very collective in orientation, but that's been impacted by colonisation. The Pacific Island communities also had the lowest rates of loneliness, it's 18%, but again I think there's a lot of modern challenges increasing loneliness in that community. And I didn't expect it, but the Asian community had the highest percentage of loneliness. And someone said, of talking with people from the Asian community, there's challenges with language, and often older people are at home and they don't go to rest homes, so loneliness was quite highly prevalent in that group. Taking this loneliness further, we wanted to look at the effect of this and other social variables on outcomes in older people. Sociologists talk about living arrangement and loneliness and other factors as being the key drivers of poor outcomes in older people, whereas medical people or other people think of blood pressure and incontinence and things like that. And having a comprehensive linked data set allowed us to explore that and to explore some of the social components and how they are predicting outcomes. Working with Sally Keeling, who was supporting me with this study, with her gerontology background, the interRAI has 4 derived social constructs which we can fit the interRAI questions into. There's one question on living alone and loneliness, and there's several questions on negative interactions and carer stress, which can be derived well from the interRAI data. This table here shows the numbers and the basic unadjusted data, but as you can see, we're dealing with data sets of pre-existing data in the tens of thousands, and a number of people were having negative interaction at home, about 10%, and carer stress was about 30%. But we can clearly see that numbers are very big, and the event rate is quite high with interRAI data in the ageing community. We then went and took forward this using modern statistical analysis and competing risks model with the assistance of Professor Philip Schluter to take a look at how these 4 social variables on the left here, are predicting outcomes. And in the unadjusted model, living alone was slightly protective against entering aged residential care. But when we adjusted for all the confounding variables where you can with dealing with the comprehensive geriatric assessment such as the interRAI, and adjusted for things such as incontinence, falls and decreased cognition, living alone was actually a big predictor of entering into aged residential care with a 43% increased sub-hazard ratio. Carer stress and negative interaction were also significant predictors of entering into aged residential care, and loneliness was also important at 18%. When we're looking at this, these are across tens of thousands of people, and aged residential care costs $1.8 billion a year in New Zealand. So it gives you an idea of how these social variables are certainly contributing to aged residential care, and where we can start directing services and policies to start to look at these big challenges in the community. So in summary, ageing and loneliness are hazard factors for increased admission to aged residential care. And all 4 predictors allow interventions to be developed and applied, and that's certainly further work that could occur. As well as looking at loneliness, we also looked at something called the Drug Burden Index, and one of the issues with older people was medications and the side effects of medications causing problems. And the Drug Burden Index is simply a summary of medication side effects. More specifically, each drug's rated for its anticholinergic or sedative side effects, and everyone gets a score from the Drug Burden Index, which it takes into account the medications and the dose of the medications that they're on. And the objective of this, which was another National Science Challenge project, was to evaluate the association between drug burden index and hip fractures in a community dwelling population aged over 65. If we look here, we see the distribution of drug burden index in the population, which was, the population size was over 50,000, and 45% of people were on no drug burden index drugs, but about 30% of people had a drug burden index score of 1, and very few people had a score of 4 or higher, because that would mean you're on the maximum dose of 4 anticholinergic or sedative medications. This table here looks at the outcomes and the unadjusted and adjusted hazard ratios. So just looking at the numbers, again, in each group we've got very high numbers generated from this large pre-existing New Zealand data set. And not only numbers of people, we're getting a large numbers of hip fractures. In this group, in the 2-year follow-up, that's almost 2,000 hip fractures. So a huge number were having interRAI assessments before their hip fractures. And if we look at I'll just concentrate on the adjusted data, which is the right column. People with a drug burden index between 0 and 1 had a 12% increased risk of hip fracture over the 2-year time period. That was after adjusting for all the confounding factors we can in the interRAI, such as body mass index, age, sex, cognition, incontinence, etc. People with a drug burden index between 1 and 3 had a 32% increased chance of hip fractures, and greater than 3 had a 52% chance of hip fracture. So clearly you can here see a gradient linking hip fractures with medications, and it's what we were quite impressed with was the dose-response relationship here, which again gives more evidence that medications are related to hip fractures. From a scientific perspective, it's quite interesting because many studies show that people on more medications have worse outcomes. But the criticism of the study is that these people are on more medications because they're sicker. Here with interRAI, you can adjust for all these using all these as confounding factors, and after we separate for multiple confounding factors, there is a very strong correlation between drug burden index and hip fractures, and it's a dose-response relationship with quite a significant effect size. The next thing we've looked at is frailty, which is another big challenge in the ageing population. As you'll know, frailty is something that's managing and identifying people who are frail is a big challenge. And what we did is we wanted to derive a frailty scale from the interRAI using the existing New Zealand interRAI home care assessment. And to do that, we statistically derived it, but also took inputs from focus groups around the concept and what older people thought was important as frailty, including some Maori frailty focus groups. We chose questions from the interRAI assessment, and we used a cumulative deficit model where people could get get their frailty score derived. The mean age of the participants was 82, and 60% were frailty, and people's frailty scale would be between 0 and 1. If they had all 49 deficits, their frailty score would be 1, which is basically clinically implausible. If they had 0 out of 49 deficits, their frailty score was 0. And this next Kaplan-Meier curve looks at how frailty predicted mortality in the people who have had interRAI. And as you can see here, people with the lowest frailty score had a 30% mortality up to this period here, which is 1,500 days. People with a frailty score of 5 or the highest frailty score had a 95% mortality. So the frailty score was quite a good predictor of mortality. We did different comparisons for Maori and European, and they're both following the same trajectory, so it did correlate across both ethnicities as well. And if you're a clinician or Treasury or the Ministry of Health, understanding predictive life expectancy using existing data is quite important, whether you do hip replacements on older people or how much rehabilitation you do given their current state and their predicting and understanding their life expectancy. I think it's important to take data and move to interventions and move to actual programs to improve outcomes. And we've been fortunate enough to get sponsored for an interventional trial, which effectively takes together the drug burden index and frailty components of this. And it's been sponsored by the Health Research Council. And what the trial does is it's actually taking older people who are on too many medications as identified by their interRAI assessments. We're getting pharmacists to go out to their homes and assess them and make suggestions for medication reduction, which are then carried out by their GP. And the whole idea of this is to see if pharmacy review of medications is improving outcomes and which frailty group benefits the most. Is it high frailty, low frailty, or medium frailty? And this has been planned with the CDHB with a clear translation plan involved, where if this works, they will start using it to treat people in the community. Because we've got a cost-benefit analysis with this as well, and we're going to measure their outcomes in terms of medications, but also events such as hip fractures and early interventions and early admissions into aged residential care. Probably the thing I wanted to talk about now and spend a little bit more time on is impact, because as I said earlier, I think, and many people have said, is that data is going to change how New Zealand is. it's going to change the world. And there's so much data there, and the key is not just getting the data, but it's affecting health policy and affecting the lives of the older people and their whānau and the people that I see on a day-to-day basis, and many of you will see on a day-to-day basis. I'm really pleased with the HRC and the National Science Challenge, how they've identified impact as a new strategy to help guide research and guide research funding. And it's really important that we are planning research collaboratively with Māori clinicians and the research team, as well as also the health system. And the research has been planned and is linked in with the health system. At a community level, we're engaged with the Tītauranga Kāmatua Collective, who advise us on issues related to Māori, and the Tātou Painemu Trust. Also with community groups, we've linked in with the University of Third Age and Rotary. But I think there is a lot of scope and very important for us to address these issues with the national media. Big data is really important, and to get the public on side is something that needs to be is going to benefit us all, and particularly benefit older people, younger people, and the whole society. They really like stories on ageing, and here's a couple of examples. The loneliness story was really popular, actually. I didn't realise how popular it would be, and here in January I was interviewed on the project, and that's with Ali Mao, who was on the guest panel that day. The Drug Burden Index story, when that came out, that was published in a number of sources too. And here, this is Te Matatika, which is actually the press. It had changed its masthead appropriately for Māori Language Week, and that Te Matatika is the face of the truth. But the story of the drugs and the elderly was on the front page of the press, again appropriately highlighting some of the changes and challenges with what research is showing in the older people. And it was great that age concern was also quoted in that story in the press on the front page as well, because we've taken the age concern, one of the translation partners, into media interviews. It's been great that the research has been on One News 3 times, including the Drug Burden Index story got the headline earlier a month ago. It was the main story on the news. Also, I've been interviewed with live interviews on News Talk ZB with Mike Hosking, and most newspapers around New Zealand have carried these stories. They don't always talk about the big data. They sometimes go with the more emotive things, such as loneliness or drug side effects in the elderly. But I think it still is starting to get the big data story out there, and how what data is showing in New Zealand, and how important it is we start to use it. I think also it's important to be linked in with the health system. One way to improve outcomes in older people or in anybody is to policy. Another way is also to be linked with the health system, because they deliver it. And I've been very lucky to be supported. I know that also the health system can be quite resistant. Doctors, including, can be quite difficult. And trying to, as well as managers, and it's really important to be working on a day-to-day basis with them and informing them of the data, because a lot of these things that we're talking about can start to be automatically done, and having them engaged and understanding what this is showing and able to be used is going to be really important to any rollout strategies, because data and automaticity are going to change the world, and a lot of things such as the Drug Burden Index can potentially be automatically generated with emerging and in fact some cases present electronic technology. I also wanted to acknowledge the Ministry of Health, particularly the Older Persons Division. I work with Ross Judge and Phil Wood and Technical Advisory Services, who have been involved with the rollout of interRAI in New Zealand. Moving on to the future, look, I think that, going back to the slide from the start, that data is going to change the world. It's an ideal way to understand human behaviour, and we are all following what is our path in different ways, whether it's be our upbringing or our diet or our medications. Everything can be better predicted by data, and understanding data is going to be a way to generate policy and generate and improve the lives of older New Zealand does have novel data sets on ageing, and in fact on many areas of life, and I think it's really, really scientifically exciting material that we're all dealing with, and combining the data with service delivery to help make things more precise, and understanding that what the challenges are for older people. They're not just doing worse because of their medications or incontinence, it's because they're lonely and the social isolation, and the degree of that, and putting exact numbers on it can help everybody understand what the challenges and what the exact issues in ageing are, and making our care more precise. And look, I honestly say as a geriatrician, without being improving data and allow bettering targeted systems would save $50 million a year. You can see it. It's very hard to make the changes, but that's what you can see. Particularly as the data and the interRAI allow us to benchmark better and compare my performance with other clinicians, but perhaps compare Christchurch with Invercargill or Auckland, compare Christchurch with or compare Maori and non-Maori and Pacifica. The data doesn't lie, and it's showing some quite important, nationally significant things like the other speakers have shown that needs to be translated and made important for people. Finally, I'd like to acknowledge the research team that we've worked with. I think the National Science Challenge and the HRC have made it clear this is a multidisciplinary team. It extends beyond a research team. Whakapiri Bolmore is a clinical assessor who does interRAI assessments in Christchurch, and I'd like to thank Cameron Lacey and Annabelle Ahuri Driscoll as well. I'm very supported by a clinical translation team. Carolyn Gullery from the CDHB puts a lot of time into making sure these research can be followed through into patient care. And I've also been lucky to do some leadership courses and change management courses within my role. Nigel Miller and also Phil Wood are also specifically really helpful and available to help this be used and understood. And also Dr. Bridget Meehan has done a lot of excellent work around New Zealand to prepare the interRAI and get it rolled out nationally. Our scientific research team, I was very lucky to have Professor Darrell Abernethy, who was the Deputy Director of Drug Safety with the FDA, and he was really excited how this data set from a scientific perspective could advance our understanding of of geriatric pharmacology. And unfortunately he passed away last November, but he was involved with both projects until particularly the Drug Burden Index project. Also from our team, Sally Keeling was a very important co-investigator who co-led the social engagement research with me, and she's been involved with the interRAI board right from the establishment for over 10 years. And very kindly, she's here today. She's also retired, and she's also happy to support us with ongoing research, so I'm very grateful for that. Also, Philip Schluter's been a key support. He's, as we deal with big data sets, we have to do new models, and competing risk models haven't been done in much ageing research, but it's really important when you've got multiple things going on and multiple events you take into account survival when people entering rest home care. Rebecca Abbey has been a PhD student, and she's just finishing, and it's been great to have her work through the National Science Challenge. And also Vicky Cameron's here today, so thank you to her. Thanks.